Good afternoon, everyone. Welcome to the Game Center webinar, Bringing Forensic-Assertive Community Treatment to Local Behavioral Health Systems. I'm Neil, Senior Research Associate at the Game Center. I want to start with a couple of housekeeping items. First of all, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Also, a reminder that you will have an opportunity to submit any question at any time throughout the presentations through the Q&A pod. So at the end of all of the presentations, we'll attempt to address as many questions as time permits. And we want you all to be aware that this webinar is being recorded. So just an overview of the agenda. We have a lot to bring to you today, a lot of helpful information. We're going to start with a basic overview of FACT for those of you who are interested in more information about what FACT is. And then we have 4 presenters following who will share about the implementation of FACT in their local communities. I'm going to introduce our speakers in a later slide, but for now I'll turn it over to Jenny Simpson at SAMHSA for some opening remarks.
Great. First of all, welcome, and I would like to thank you all for joining us on this webinar. We have a fantastic lineup of panelists to share with you timely information about the growing use of forensic-assertive community treatment. I'd also like to thank our presenters for bringing their expertise, experience, and clinical practice to the field through this webinar. Earlier this year, SAMHSA brought together a group of experts and clinicians, including our presenters today, to better understand how FACT teams are being used across the country and to identify key elements that differentiate FACT from community treatment. To act as an evidence-based model, we were interested in hearing from our experts and clinicians on how they have adapted the model to fit working with justice-involved individuals. Webinar, you will hear variation in how FACT teams are structured and implemented in several programs across the country. Walk away with ideas on how to improve clinical practice with justice-involved individuals who meet the criteria for ACT and may have increased improvement in their health, behavioral health, social legal outcomes with specialized FACT teams. Now I'll turn it back over to Melissa, who will provide you with an introduction to our panelists.
Our first presenter today is Dr. Gary Kulak, and he's an associate professor at the School of Social Work at UNC Chapel Hill, University of North Carolina at Chapel Hill, and is also a research fellow with the Cecil Shep Center for Health Services Research. In his research, he is well published and has extensive research on people with severe and persistent mental illness, and particularly those who are involved with the criminal justice system and have chronic and disabling mental health and physical health conditions. Following we'll have Jessica Claver, who is the Director of Community Programs at CASES. She's been a clinical and forensic psychologist with more than 15 years of experience in clinical research, administrative, and teaching areas. And so she's got an extensive history in this area. She holds a Bachelor of Science in Psychology and a PhD in Clinical Psychology. Is the SMI, Serious Mental Illness Administrator at Community Bridges, and he oversees forensic ACT teams and traditional ACT teams. And he served as Community Bridges' first FACT team employment specialist, and prior to that was a peer support specialist for one of Community Bridges' crisis programs. And so he has a story of recovery that he shares and has taken advantage of the opportunities made to him to make a career and a life to help people who have been through some of the things that he has experienced. Don is the Director of Integrated Care for Community Bridges. and she holds a master's degree in clinical psychology. And she directly supervised clinical and administrative leadership of CBS FACT teams. Uthington is an adult probation supervisor in the Adult Probation Department of the Serious Mental Illness Unit in Maricopa, Arizona. She has a Bachelor of Science in History and Political Science. She's been with the Maricopa County Adult Probation Department for 12 years and has spent that time working specifically with serious mental illness, and domestic violence, and related issues. I will turn it over to Gary to kick off these presentations.
Thanks, Tarek, thanks so much, and like SAMHSA and the Gaines Center and PRA for the opportunity. And thank you, participants, for joining today. I'm looking forward to the opportunity to share some of what I've learned about FACT. There's lots of expertise on the phone and also in the literature. So others out there have been writing and conducting research about FACT. So I really don't want to seem as if I'm the preeminent expert in this area. Nevertheless, again, Forensic-Assertive Community Treatment is an adaptation of assertive community treatment. So what I'll do in the time that I have is a little bit about criminal justice and mental health. The complex needs of justice involves individuals living with severe and persistent mental illnesses, and go over some of the results of literature synthesis I did for SAMHSA related to FACT, and then it'll be my part of the presentation today. As mentioned, I'm here at the University of North Carolina School of Social Work and also Shep Center. So let's see, there we go. So this will be not information for most of us on the phone, but the intersection of criminal justice and mental health. As we know, the public mental health system has shrunk in the past 50 years, where 50 years or longer ago, folks were state psychiatric hospitals. Now they've been diffused to a number of different publishers. And if you think about those state hospitals, care and treatment were together. So most setting aside the quality of care and treatment, but the fact that folks were housed, they were fed, they had recreational opportunities and so forth, in addition to treatment, those things were together. Well, since we deinstitutionalized our state hospitals, care and treatment are now separate. And we all know individuals with mental illness have to go one place for mental health treatment, another place for housing, a separate place for vocational rehabilitation, another place for physical health care, these are all systems that individuals with persistent mental illnesses now have to navigate. And for the second bullet, the criminal justice system is now a new frontier for mental health services and services research, and it's often the criminal justice system where we go to try new interventions for individuals living with mental illnesses or new policies and so forth. So it's an unfortunate reality. Health and quality of life outcomes for people with severe or persistent mental illnesses are now significantly impacted by criminal justice policies. New city ordinance that crack on panhandling, for example, those are most likely to affect those who are most vulnerable and marginalized. So if you tweak the criminal justice policies, it often has an impact on the health and quality of life of individuals with persistent mental illness. If you think the justice system, it really is the place of last resort for people in the community, difficult to manage, that are violent, that are not compliant with treatment or not adherent with treatment. About hospitals and emergency departments, those institutions can often refuse care for folks who are particularly violent, whereas jails can't. And if you think about the criminal justice system, it's often, unfortunately, the first and best opportunity for some of these individuals to get diagnosed with either a behavioral condition, substance use, or physical health condition. I work with local criminal justice agents, jails, and prisons here in North Carolina, and stories that come in, and it's the first time they get diagnosed with advanced cancer or diabetes or infectious diseases and so forth. So unfortunately, you can often view the criminal justice system as a public health outpost for people with severe and persistent mental illnesses. I'm trying to advance. So persons with severe and persistent mental illness in general have complex needs. When you layer on the criminal justice system, I would argue that is a level of complexity that is even greater than those without justice involvement, which includes greater risk for homelessness, impact of stigma and discrimination, violation, substance use, physical health. These are all things that are exacerbated by involvement in the criminal justice system. And the things that many of you on the phone, many of you participating in this webinar, are encountering every day. So the point here is the complexity of needs when you layer on the justice involvement is increased for individuals with severe and persistent mental illnesses. These figures, this next slide, from some of the research I'm conducting now with probationers with persistent mental illness here in North Carolina. So this is part of a study I'm doing on specialty mental health probation. And these are data from a life event checklist, which is a report of cumulative trauma events. And these are some preliminary data from this research. So these are 127 probationers who have schizophrenia, bipolar disorder, major depression, or post-traumatic stress disorder. And the life events checklist asks about 18 different traumatic events that someone might experience. And these are the top 5 events. So you can across the board, and again, these are probationers with severe and persistent mental illness. Almost 80% had been involved in a car accident. Almost 80% have been physically assaulted. Over 50% assaulted with a weapon. Over 50% experienced sexual assault. And below 50% experienced some kind of life-threatening illness or injury. So these figures are remarkably high and just remind us of the exacerbated risk of trauma that justice involvement, severe and persistent mental illness. Informed care, in addition to what we'll discuss later with Forensic-Assertive Community Treatment, has to be part of the menu of services that are provided. And again, these figures just illustrate the undiagnosed, untreated trauma that underlie the behavioral health issues and substance abuse issues experienced by this population. Much of our strategy has been so far to get folks with severe and persistent mental illness who are justice involved back into treatment. So most of you are familiar with the sequential intercept model, where being at different points along the continuum of the justice involvement, just folks back into mental health treatment. So we have interventions at the law enforcement level with intervention training. We have mental courts. We've got services in jails. We've got discharge planning and reentry planning, jails and prisons, and then specialty mental health probation. As I said, interventions are focused on connecting justice-involved persons with severe mental illness into mental health services. It kind of means that it's mental health that is related to or the cause of involvement in the justice system. mental health services, or if mental health has little to do with involvement in the justice system, might be other factors at risk. And there are criminologists and sociologists out there that orientation for the reason why individuals are involved with the justice system. And this comes from research, meta-analyses of factors related to justice involvement over the last 10 or 20 years. Criminogenic risks, and if you talk to Department of Public Safety around the country, they're focused on addressing these criminogenic risks among prisoners, folks in jails, folks in prison. So the criminogenic risks are listed here: antisocial behavior, antisocial personality traits, antisocial cognition, antisocial associates. Those are known as the big four. And other criminogenic risks include substance abuse, family-marital conflict, low levels of education, employment, lack of appropriate leisure and recreational activity. So we have interventions that address these criminogenic risks, particularly the top four. Interventions like moral recognition therapy, reason and rehabilitation, and thinking for change are widely used for individuals without mental illness who are justice involved, and we're beginning to see adaptations of these for those with severe mental illness who are in justice involved. One of these now, these treatments and behavioral treatments are being added to mental health interventions that we'll talk about later. Is there a synergy between mental health and criminogenic risks? And one way to think about this is for whom the substance use addiction going to be worse for? Someone who has a diagnosis of schizophrenia or someone who does not? I think we can all guess the answer to that one. So it's synergy between mental health and criminogenic risks that makes justice involvement and recidivism exacerbated. So here, again, from studies I've done here in North Carolina, we look at several of these criminogenic risks, and this is a sample of probationers, both with and without mental illnesses. And the context here is, as you think about forensic-assertive community treatment, well, what is the menu of treatments or interventions we need to add? So do we add interventions or that address criminogenic risks as well as interventions that address illness? Well, here's some context for that. What we see in red are probationers with severe mental illness, and blue are probationers without severe mental illness. And you can see across the board that individuals with severe mental illness who are on probation have higher levels of these criminogenic risks. So a synergy between mental illness and these criminogenic risks that result in revocations, higher recidivism rates, and so forth. That's the context and the complexity of need among individuals with severe mental illness who are involved in the justice system. So we talked about higher rates of trauma, we talked about higher levels of these criminogenic risks, and if you think about a treatment model now beginning to incorporate some of these different factors in treatment, is what we'll hear now. So, forensic-assertive community treatment. What do we know? What do we need to know? This is from a piece of literature review a couple months ago. SAMHSA. Do is I'll just highlight some of the findings from that to stimulate our discussion. So some basics of the review. It's a systematic search of computerized article databases, PubMed, PsycInfo, Web of Science, and then also looked at the reference sections of articles identified through the systematic research, and then reviewed the content of 47 articles. Eligibility was one of the themes or areas that I focused on. There has been an established eligibility criteria for ACT for years, which is a severe and persistent mental illness plus hospital use. Use the definition of 2 or more hospitalizations in a calendar year, some do 6 months or more in a state hospital. But nevertheless, it's profound mental illness, severe and persistent mental illness, which is typically defined by 3 Ds, so diagnosis, duration, and disability, plus level of hospitalization use. So fact eligibility, there was variability in how that was defined. So there's agreement in the studies I looked at that severe and persistent mental illness was a starting place, but there's variability in the definition of justice involvement. Some current or past justice involvement, whether that was with a court, formerly incarcerated in jail or prison, currently on probation, was often used. Some used a threshold of justice involvement, like 2 or more jail detentions in a calendar year or 3 or more jail detentions, but in terms of justice involvement was defined. So that's difficult in terms of establishing effectiveness of fact, which we can talk about in a little bit, but with a standardized definition of fact eligibility with respect to the involved, it made it a little harder to decide who we're talking about. So, as we all know, there's gradients of involvement with the criminal justice system. The deeper you penetrate, the more severe your involvement is, obviously. So again, just a comment on the variety and the variability in fact eligibility. So, what was in the literature, there's a thinking that any good ACT team should be able to address the needs of justice-involved persons with severe and persistent mental illness. Others address the special experiences and skills related to criminal justice involvement that were needed. So, use is a big part of the clinical of individuals with severe and persistent mental illness. So certainly being able to address substance use, trauma, as we discussed, is very prevalent in justice-involved populations. That are motivating and authentic and non-judgmental, and that these individuals with their justice involvement are coming from that have been very judgmental and fully motivating and very restrictive and so forth. Some skills to be able to relate to these individuals is particularly important. Knowledge of the criminal justice system. So being able to work with professors, being able to work with jail staff and prison staff, being able to understand their mission and their language are all key elements to the special competencies and staff needed for FACT. Being able to address the complex needs of consumers. So as we described earlier, these individuals have lots of trauma, poor social networks, lots of health problems, lots of substance use. So putting all of that together, being able to have all those different expertise on a team is important. So FACT models, there was a variety of FACT models out there and variations in what FACT teams did in the literature. So the models were connected to residential substance use treatment facilities, would be particularly important after discharge from or release from a criminal justice setting. It was a component that some FACT teams had. Teams were split, whether agents of the criminal justice system were on the team or on the team but collaborate close. So some teams, for example, had a probation officer on the team functioning as a team member, attend team meetings regularly, maybe not daily, but regularly, where teams having the criminal justice system close could erode therapeutic rapport, make it difficult to have trust with the consumers on the team. This included addressing criminogenic risks through CBT interventions, ones that we talked about, so elements of thinking for a change or elements of reading and rehabilitation were part of the FACT model. Fidelity, typically FACT teams adhered to ACT fidelity standards. With respect to fidelity to FACT, we don't have any fidelity measures to address the criminogenic components that FACT teams should or could adhere to. In terms of relations of FACT models, some were connected to jails and jail reentry. Some were prison reentry models. Some were just in the community, connected to mental health courts. Some were in the community connected to probation. So there's a variability on where these models were situated. Enhancing and sustaining FACT, there was lots of variability in that. Many of these programs were started by seed grants that gave lots of flexibility in what could be funded and how consumers could be supported. Some were dependent on Medicaid, which Medicaid often come along with rules that are set by a state in terms of who can be served and with what menu of services. Enhancing and sustaining FACT seems to be an issue for many teams and always been a struggle. And there's alignment, and if you think about it, who gets and who pays for FACT. Well, if FACT is successful in keeping inside of the criminal justice system, however, the scene of it is often on the shoulders of the community mental health system. There's a misalignment between who benefits and who pays there. So focusing and sustaining FACT, just like ACT, it continues to be a challenge. And what should we expect from FACT? Should we expect improved criminal justice outcomes in terms of the reduction in recidivism, or maybe reduced violations in terms of few technical violations? So I have individual behavior. So do we expect FACT to be able to address the behaviors that are involved with criminal behavior? And technical violations, is FACT successful at working with probation officers, for example, to collaborate around alternatives to justice involvement, reincarceration, and so forth? So, and then improved mental health and substance abuse functioning. There's evidence that ACT and FACT, as we improves mental health and substance abuse functioning, reduces hospital use, improves housing and stability. Some evidence that quality of life can be improved. So, evidence that FACT can affect both criminal justice outcomes and improve mental health and substance abuse outcomes. Certainly, evidence about FACT gets implemented and how it does these things is needed, but evidence regarding these improved criminal justice outcomes and improved mental health and substance abuse functioning is there. FACT standards, we can think of, for whom does FACT work, under what circumstances, and with what outcomes? Do we work with the basic structure of ACT and then scale up and down with some of the following components? So enhance clinical competencies and components. We need to address the criminogenic risks. We need to substance use, physical health, housing, of course, and then figure out how to collaborate with the criminal justice system. To engage, very hard to engage mistrustful population, take social competencies among staff and skills, financing, which could allow for prolonged outreach and service to non-Medicaid clients. If you think about FACT, that the model produce individuals that really have been falling through the cracks and have been in and out of the justice system, maybe in and out of the hospital or state hospital system, who Medicaid eligible. It takes a time and effort to reach those folks to develop the kind of therapeutic rapport to engage them in services. I've heard from teams around the country up to 2 years to really engage these folks and get them involved in services. So while you're trying to engage these folks and they're non-Medicaid eligible, those services that can't be billed for, obviously. So having flexible funding and full financing that allows you to engage these hard-to-engage and hard-to-reach folks is important. And also, how can we share resources between mental health and criminal justice systems, better align who benefits and who pays? So there might be important issues going forward as we think about keep these programs afloat. Lastly, as we all know, there's much more to justice involvement than just mental health, and we're beginning to understand the factors that are related to justice involvement among individuals with mental illness. And mental illness is most likely a smaller role than other factors that are included in involvement with criminal justice. So I like to say, to give folks a bed, a buddy, and a job. Well, we get individuals housing, employment, and pro-social support and foremost, and they take care a lot of justice involvement for individuals with severe persistent mental illness. Then laying on top of that, the mental health treatments and interventions to address criminogenic risks. So it's a bigger picture and a bigger context than just mental health services and behavioral treatments to address criminogenic risks. All these other things that ACT and FACT teams are already trying to do really come into play when we think about practice policy and so forth. So determinants of justice involvement, just like we're trying to address social determinants of physical conditions. Such that concludes my portion of the presentation. I look forward to questions and answers.
Hi, everyone. My name is Jessica Klaver. I'm the Senior Director of Behavioral Health Services at the Center for Alternative Sentencing and Employment Services in New York City. Thank you, Gary, for that introduction to Forensic ACT, and thank you to SAMHSA for inviting me to present today on Forensic ACT in New York City. Our mission is to increase public safety through innovative services that reduce crime and incarceration, improve behavioral health, promote recovery and rehabilitation, and create opportunities for success in the community. CAPE opened its first program in 1967, and currently we have 27 programs operating out of offices in 4 of the city boroughs, serve nearly 6,000 youth and adults each year. We have a court services division, an education, career, and enrichment division, and a behavioral health division where our Forensic ACT teams lie. And we now have cases, 6 ACT and FACT teams, making us the second largest ACT provider in New York City. We began operating in New York City in October of 2016, and cases was awarded 3 of these teams, so run the 2 Manhattan FACT teams and also the Brooklyn FACT teams. The admission criteria for Forensic ACT in New York City is grounded in core admission criteria to an ACT team. This is for adults who are diagnosed with a serious mental illness, most often schizophrenia, schizoaffective disorder, bipolar disorder, and who have not been well met by more traditional service delivery approaches, for example, outpatient clinic. That client is also going to have recent or current criminal justice involvement. This is usually in the past 12 months. And their criminal justice involvement is related to the presence of their serious mental illness, or it's related to episodes of noncompliance with treatment. So how to get on a Forensic Act team in New York City? Here in New York, the Department of Health and Mental Hygiene has a single point of access, or SOA system. Individuals can be referred for a variety of services, including care coordination, Forensic Act, and the SPOA evaluates referrals and then sends them out to providers such as ourselves. Note that there is priority access for ACT in New York City for those who are on assisted outpatient treatment orders, or AOT orders, and these are essentially court mandates for outpatient treatment for people with serious mental illness who had episodes of non-adherence with their that have resulted in violent behavior. Look at how a Forensic Act team is staffed in New York City. Here I have by regulation, the staff members of a traditional ACT team, and in blue we can see here forensic enhancements that we've built in. So all ACT teams have a team leader, 2 substance use specialists, a family specialist, an admin specialist, a peer specialist, a wellness specialist, a program assistant, a nursing staff, and also a few psychiatry staff. In the FACT model, what we've done is we've added a second peer specialist, and this person we aim to have lived experience, him or herself, in the criminal justice system. We've added a housing specialist because one of our greatest needs that we see for our clients, and a justice specialist who's really the point person for sort of the criminal justice coordination that happens on the FACT team. And all FACT and ACT teams in New York State serve 68 clients maximum. The training that our FACT staff receive is based in the core training that all ACT staff receive through the ACT Institute. That's through our Center for Practice Innovations in New York State. So this is a series of in-person and online trainings that all new ACT staff take to learn evidence base of ACT. ACT staff, in addition, receive a criminal justice and behavioral health certificate through the Need for Justice Informed Practice. So there's a series of in-person courses where they learn some basics about the criminal justice system and also how experience in these systems impacts our clients. All ACT staff are trained to administer 2 risk assessment instruments. The first is a criminogenic needs assessment, the level service case management, or the LSCI, which many of you I'm sure are familiar with. And the second is the HCR20, which is a violence risk assessment and management instrument. Actual FACT services, again, based in sort of the core ACT services. So on the left, you see the ACT services that are provided to all recipients of ACT in New York State. And I'll talk a little bit about some of the enhancements that I think are essential to the facility of Forensic Act, and we've seen it thus far. So all clients receive a comprehensive psychosocial assessment, but in Forensic Act, we do an expanded legal history assessment. So we have access to our clients' sheets, review them collaboratively with our FACT clients, just to look at some of the experiences they've been through in the justice system, and if they have any current criminal justice needs, such as an open case or being on probation or parole. Receive a criminogenic needs and a violence risk assessment. The idea here is to build on a traditional ACT service plan to intentionally build in services that reduce risk. So risk for offending, risk for violent behavior. We arm handoffs with our criminal justice partner providers. So this might look like a defense attorney when someone's being released from court. We'll pick someone up from court, or jail staff at our city jail, Rikers Island. We escort them from Rikers Island to their housing. We do retreat work with our FACT clients, and we find traditional ACT, a lot of the transitions, service planning, coordination services have to do with clients being discharged from inpatient psychiatric hospitals back to supportive housing or living with a family member. And in fact, a lot of that transition work looks a little different, like someone coming out of a correctional setting and going, unfortunately, into a shelter system. So that does have some unique needs. We do continuity of care during incarceration. So sometimes our clients, go back into jail, and a lot of providers, when this happens, they may sort of wait and see what happens, or discharge a client. But we actually go to the jail and visit our FACT clients. We talk to the defense attorneys. We show up at their court dates, and that allows us to do quite a bit of legal advocacy. So that might be standing up and describing to the judge what forensic is and advocating that for them to be released back to us into the community. I like to think that we provide kind of a specialized trauma-informed care for the justice involved. Of course, attending to a lot of the traditional traumas that we assess for in mental health. But our staff, we like to make sure they're trained also in what we feel is the unique trauma of incarceration itself, and ensuring that our staff are sensitive to those needs in our clients. And we have an explicit focus on legal outcomes, so not only on kind of traditional ACT outcomes, but positive legal outcomes, which might include some successfully completing probation or parole, or not being rearrested, or being rearrested less frequently. Just a look at some of our early LSCMI data, our first 80 that we've administered to our Forensic Act clients in New York City. And we have their criminogenic as measured by the LSCMI. And what we can see here is that on average, our clients have, needs in the area of their criminal history, highs in the area of education and employment, medium needs in terms of their family and marital relationships, varied needs in terms of how they're spending their leisure and recreation time, and also their companions who they're spending their time with. Medium needs in the area of alcohol and drug problems, which I will say is probably not unique to Forensic Act. We have this interesting bimodal distribution for criminal attitude and orientation. We're a group that has very low antisocial cognition, and then also another separate group that seems to have very high levels of antisocial cognition. Antisocial personality patterns, generally kind of medium needs in that area, and overall high criminogenic needs. And this tells us is that we really are treating a population here in New York City in Forensic Act that is significantly at risk for further justice involvement. Of our essential criminal justice partnerships. At the level, we have the Department of Corrections, the Department of Probation, our local jail, Rikers Island. Many of you know is one of the largest mental health providers in the country, where 15% of people in Rikers Island have a serious mental illness, and over 40% have a less serious but diagnosable mental health condition. At this level, we work with state prisons. We get a handful of discharges straight from state prison to our forensic teams, sometimes for people who've served 20, 25 years in state prison. So it is also a reentry challenge. We work a lot with parole. We're sort of always in and out of the parole offices. We find it to be a good opportunity for engagement. Sometimes our clients may prioritize their parole appointment a little bit more than their forensic act treatment. So we can go to parole and engage them. Also educate parole about health generally, forensic act, and building these relationships, I think, comes in very, it's very important. Comes to a point where maybe a parole officer is thinking of violating someone, and we can really work to keep them in the community. So really all the players in the courts, from the judges to the defense attorneys to the prosecutors, work with a lot of alternative to incarceration programs. Sometimes our clients are in these programs, or we're in court advocating for them to be released to these programs. Especially in Brooklyn, we worked a lot with some other specialty courts, like the Brooklyn Mental Health Court, the Brooklyn Treatment Court, which is for individuals who have substance disorders, and also New Young Adult Court, which offers alternative to prosecution for individuals up to 24 years old who have been arrested on a misdemeanor charge. How do you pay for Forensic Act in New York City? New York Act itself is a Medicaid service. So we're paid on a per member per month basis, depending on how often we see the person. So we see a Forensic Act client 6 or more times per month. We can bill Medicaid at what's called an intensive full rate. If we see someone 2 to 5 times per month, we'll at a less intensive or a partial rate. All persons in the hospital for the entire month, and we do go see them a few times, we're able to bill at this partial rate. New York State, as part of a larger Medicaid reform effort, Medicaid has transitioned into a managed care model. So this has changed operations a little bit. We're always on the phone calling managed care companies, trying to get more services authorized for our clients. And importantly, this provides deficit funding for our forensic act teams at a rate of $650,000 per year. And this is really essential to the functioning of the teams, the sustainability, being a Medicaid service with people who are in and out of incarceration situations. Their Medicaid is not always active, so it allows us to continue care in those situations. We do have one other ACT team that is also an alternative to incarceration program at the same time, and CASES has been able to grant funding for this program from the city and the state that we've been able to maintain over the years. So thank you very much, and I look forward to your questions.
Hello, Dawn Whittington, Community Bridges. I'm the Senior Director of Integrated Care, and I'm with Jeremy Reed. He is our SMI Administrator. And thank you to all who are participating, as well as to SAMHSA for allowing us this opportunity. Jeremy and I are going to be focusing on the Forensic-Assertive Community Treatment here in Maricopa County, which is Phoenix is located in Maricopa County. So we're going to really be focusing on our work in the Phoenix area. Our first FACT team was started in 2014. I think a key component, and you'll be seeing this throughout our presentation, is really involving the peer staff. At that time, 58% of our first FACT team was consisted of staff with shared life experience. So this is staff that may be in recovery from substances, may have experienced homelessness, involvement with the legal system, or mental health issues of their own. And since that time, we have added a second and a third FACT team in 2015 as well as 2016. We also operate 3 ACT teams in the Maricopa County area, but we're kind of focusing on our FACT models at this time. I think the other key component is that all of the FACT teams really follow the ACT fidelity model. So that is, teams were providing that hospital level care in the community up to 100 members at a time. The FACT teams are doing those 4 face-to-face visits, 1 in-home visit per week with the teams that the members that they're working with.
So some of the essential elements that we feel make us successful providing FACT services here in the Phoenix area, the front is hiring the appropriate staff. And that doesn't mean that there's some huge screening metric that we run applicants through, but it's really very hard work. So we would make sure that we know that we have someone that is passionate and motivated about doing this work, rather than just filling it with a body. Part of that also relates to what Dawn was talking about earlier is, all of our staff have the lived experience, but we have found that to be very beneficial. Part of that looks like knowing what it's like to be incarcerated. A lot of times for some of our members, their living conditions may improve if they're incarcerated. Understanding that there is not a fear of going to jail, but more of a fear or anxiety surrounded being released from jail. We also really try to create a positive work environment for staff. It is, like we said, very difficult work. We hear a lot that the clients or members or patients need to come first. The leadership at Community Bridges believes that, but also believes that the staff have to come first as well, because they are the ones providing the services to our patients in the community. And if our staff isn't supported and feeling healthy and feel like they have a voice, then really the clients in the community, will suffer. I was going to talk a lot about the collaboration a little bit too. We think this is very, very important, and I think we're very fortunate here in Maricopa County, because for FACT to work like it's intended to, you have to have the buy-in, not only from the agency that you're working for, but also a lot of the community stakeholders. So the probations and parole officers, we're fortunate we have buy-ins. The mental health professionals in the jails and the prisons, when someone is either going to jail or prison or getting out of jail or prison, we are coordinating and collaborating with them regularly. Landlords in the community, when we're meeting with someone who has a criminal history with, maybe some other barriers surrounding evictions or lack of rental history, creating a relationship with the landlord, is very important. Gary was talking about how important that bed is for our members, and creating the relationships with the landlords, we feel is also important. And then the natural supports. Someone gets referred to one of our FACT teams and starts getting services. We have a very limited history on them, but in the family, and sometimes we can get a decades long of history on our members that will help us create intentional services for our members. When we started in 2014, and this is something that's been replicated through all of our teams, we have a whatever it takes attitude for staff. Sometimes there's barriers that come into play with services or resources that we're trying to get for our members. I know this the hard way. The whatever it takes attitude for me was usually banging my head against the door until someone opened it. But the softer approach is, when those doors are closed, we then look for a window to go through. And at Community Bridges, we're really fortunate where we get the support from our leadership to have that creative outside of the box thinking.
Yes, and I think you counselors out there, you've always heard, that we can't work harder than the patients, and really, I think that's kind of a backward approach, and we've kind of flipped that that at the beginning of treatment, we're really doing about 90% of the work when we're working with a new member on our team. The staff is, actively engaging. They're, going through that window that they find, whatever it may be, with the idea that over time, then that kind of continuously graduates to they're doing 90% of the work and we're doing 10% of the work. And of course, that can kind of go back and forth at different times, but really, we don't take the attitude that we work hard on the patient or the member. Sometimes that's what's required to get them to the next step. I think a big piece is reducing the stigma surrounding mental health and criminal justice involvement. I think, and we'll talk about this later on, we've had to really look at changing some internal policies, some changing policies within our jails and different things like that to really reduce the stigma and to really members feel welcome.
Then the last two top points here are the fidelity reviews. When we started in 2014, all we really had was the fidelity tool as a map to go off of, and that was our we knew that if we followed this guide and did things, we would get certain outcomes. So a lot of the barriers we faced and the creative thinking we had was all solution-focused, all resulted back to maintaining that fidelity review. That was sort of our foundation that we went off of, and that's also been replicated over the two additional teams that we've onboarded in the last few years. And I think a really important thing is the technology for communication. All of our staff members have personal cell phones that have been issued by the agency, so if a staff member or family member or probation officer or any of our community stakeholders are trying to reach someone on the team, they're able to call someone directly. They're not calling a receptionist who's then transferring you to a voicemail and then you're waiting for a return call. All of our staff do have laptops that they're able to bring out into the community that have access to the internet, so they can do collaborative documentation, treatment plans, assessments, all in the community. That's been very valuable. Sometimes we find someone on a corner, of outside of a gas station, and they're able to get in our car, and we're able to update a treatment plan, do an assessment, discuss some other things, and then capture all of that in their medical record. The other important things that the specialists on our team have is personal use company vehicles. So that really is assist our response time for some of the crises that come up, specifically, on call in the, after traditional working hours. Our staff are able to activate into the community to go engage the member in a very short amount of time. It really closes the window on our ability to engage our members who are experiencing some sort of difficulty or crisis.
And I think we've used that technology, carried it from using it to connect and communicate to really then provide services. So sometimes our psychiatrist may be, located in the office, and we have a member who's not wanting to go into the office. We'll have a staff person use a secured Skype link, on their laptop to then be able to meet with that member in their home when maybe they wouldn't have come into that appointment otherwise. So we really try to use that technology to not only communicate but to enhance the services that we provide as well. Part of this is, obviously, in order to be on the FACT team, a member has to have an involvement with the legal system. And here we really rely on our probation officers and our parole officers to really do some initial assessment of their criminogenic risk factors that then provide us a place to really start. And so what we do is with the FROST and the OST that the probation officers and the parole officers screen and provide that assessment to the members. And we incorporate that into the screening and the treatment that we do. The key factors of this is that we really focus on the individuals referred to us that have medium to high criminogenic risk factors. those are the ones that are going to benefit the most from the services we provide. Research shows that if you mix somebody with a low criminogenic risk factor, they're going to actually decompensate and over time when you mix them with the medium to high. So we really focus on the medium to high individual in accepting them onto the FACT team. Somebody that was low, we would likely then refer to one of our internal ACT teams so that the FACT teams can really focus on those with high risk factors and really be able to reduce those over time.
We talked briefly earlier with some of the eligibility criteria. This is the eligibility criteria that we follow specifically for our FACT and ACT teams. But of course, the main criteria that we need to have is the diagnosis. Then we also, if you can see below here, some functional impairments. They must meet one of the following. A big one that we receive a lot of is able to be taking care of daily activities on their own or inability to maintain success in traditional outpatient services. We also have to have, again, what Gary was talking about with the hospitalizations. That also includes extensive crisis facilities that factor into someone being appropriate for an ACT team. Again, living in the substandard housing or homeless or at risk of being homeless, or in an inpatient bed but clinically assessed to be able to live independently with only natural supports, and if ACT or FACT services are provided. So that looks like it's somebody who's maybe in 24-hour residential treatment but being able to transition to a lower level of care that are most likely to be successful if they also have the support of the FACT or ACT teams.
A little trouble with the slide advancing. There we go. So we kind of spoke a little bit earlier to the recidivism risk factor. So this explains a little more in depth. We occasionally take members onto the team that have been in the Department of Corrections for over 2 years, things like that, or have had at least 3 bookings in the last 24 months. Occasionally we do take individuals onto the team outside of the OST or the FROST stores, but I would say as a large part it's really having that medium to high risk factor that place somebody on one of our FACT teams.
So what our staffing or our teams look like? We have a psychiatrist on the team, the clinical coordinator, or I think as Jessica called it, a team lead. We do have 2 registered nurses, 2 substance abuse specialists, and a community bridges. They are master's level of education and have to have at least 1 year of experience in substance abuse treatment. A program assistant, a management specialist, an employment specialist with 1 year or more of employment experience, a rehabilitation specialist, and that's not so drug rehab or physical therapy, rehab. That is a specialist whose really main job is to help our members find meaningful community activity, maybe linking back them with some of their hobbies, interests, and values that they've sort of gotten away from over the last months or years. We have a housing specialist, an independent living skills specialist, a peer support specialist, and a FACT specialist. And that FACT specialist job is really to make sure that all those other components are being touched on in our members' treatment.
So as we mentioned before, that staffing component really then serves up to 100 members at any given time and really providing a hospital level of care in the community to the member.
A new staff is onboarded onto one of our teams. There is, again, a pretty rigorous amount of training that they must go through and able to sustain that position. We have an ACT 101 that we partner with our funding source here in Maricopa County. We have family psychoeducation, evidence-based practice of integrated dual disorders treatment. We have illness and management recovery, trauma-informed care, some other evidence-based practices that we make sure all of our staff are trained on are permanent supportive housing and supported employment. And then what we also do is we bring in some of our community partners to collaborate trainings and brainstorming together. So we have a very good relationship with the probation department here in Maricopa County. So we have an adult probation 101 and what that looks like for someone with a mental illness on probation, court treatment processes, mental health court processes and expectations, and that's where we have members that are involved or that are involved with the court process come and train staff, the Rule 11 or not guilty by reason of insanity defense, and thinking for change, which is really targeted to our on the FACT teams.
Yes, and in terms of financing, we really kind of have a blended model. So we have value-based contracting. So for our members that are on our state insurance, which is roughly about 90% of the members on our team, we have a per member per month rate for those individuals. For us, if somebody would go back into the jail or something like that, they then fall off the state insurance, and those members then become a fee-for-service reimbursement. We also have performance-based incentives. Some of our outcomes are looking at increasing employment, increased housing, increased access to PCP and medical care, and then decreasing jails or bookings, incarcerations, decreasing hospital, psychiatric, and medical admissions, as well as decreasing emergency room and crisis visits. So based on our performance in those different areas, we actually are able to get incentives to our agency, which then through percentages we actually then pass down to our teams. So I think that's important that the teams, you know, they're benefiting from the work that they do, you know, in that kind of tangible way, which then adds to that positive work culture and just kind of creates that circle of, you know, taking care of staff who take care of members and that sort of, you know, process. And then lastly, we do have fee-for-service for people who are, like I mentioned, on the state insurance. And we do have a few who might have like a private insurance, but that would be very, very few. So for us, that's really what our financing looks like, and it's the majority through our state Medicaid system. This is what some of our actual measurement and outcomes have looked like for our teams over the last couple of years. So as you can see, we've had a 19% reduction in homelessness, an 84% increase in visits with a medical provider, as well as in a 76% reduction in incarceration. And this is across the three teams that we have, as well as a 31% reduction in psychiatric hospitalizations, 18% reduction in emergency room hospitalizations, which really, you know, kind of creates a cost savings for our entire system and opens up some of these other, you know, resources for other community members who may be in need of that. And when we talk about fidelity scores, 2-year average for all of our FACT teams on our ACT fidelity model, out of that scale of 1 to 5, average is a 4.0 across our 3 teams over the last 2 years. Some issues. There we go again. Okay.
So part of the system collaboration that we talked about earlier is an adjustments to our policies and procedures. At Community Bridges, we have an internal program called Transition Point, which is really designed to be a 3 to 5 day stay for someone experiencing a psychiatric crisis. We've been able to utilize that, which has helped us decrease those hospitalizations or ER visits. Part of our collaboration with the county was being able to do face-to-face visits with some of our members who were incarcerated with staff that had criminal justice involvement, you know, previously. So we were able, a lot of work and collaboration to get all our staff badged, which is basically a way for them to go into the jails and meet with members, regardless of their criminal history or cultural background that they might have had being employed on the team. The training and education that we focus on is that the clinical team needs to be more focused on training on the criminogenic needs as be able to create a synthesized treatment plan. Then again, the partnership with the housing providers and landlords. So developing the relationships with the landlords, a lot of time we, as factor act teams, we turn into almost salesmen. So we're educating the landlords as well as the services that the FACT team can provide, and really the goal at that point is when we're leaving that meeting with the landlord is landlord looking at the application and instead of saying, why should I rent to this particular person, is saying, why wouldn't I rent to this particular person? And that might mean, you know, sometimes the landlord might be calling us and saying, hey, the shower head fell off at so-and-so's apartment, you know, can't make it over there until Tuesday. Can somebody from the team, you know, help them put the shower head back on? And something as small as that goes a long way when we're providing the relationships with, or in those relationships with the landlords. And they also know that we're available 24/7, so if they are having any issues, they can call us and we show up. Really also prevent maybe the landlord from going some other role involving criminal justice or law enforcement agencies.
Yeah, and then finally, really collaborating internally within our own CBI programs and clinics. We have several integrated care clinics throughout Maricopa County, which most of our members then are able to receive their PCP care and medical care through one of our PCP partnership locations, should they so choose, and a few of them do, so that they are able to receive the services, you know, in-house in a comfortable, familiar environment, and then be able to, you know, really we're able to collaborate with each other. So I think that's one of the internal benefits that we have, and something that really fits in our continuum of care within CBI. That concludes our portion of the presentation. We look forward to any questions you may have in the future.
Hi, my name is Jessica Essington. I am an SMI supervisor with Maricopa County Adult Probation in Phoenix, Arizona area. I've been department for about 12 years, and I've been supervising one of our SMI units for about the last 4.5 years. So one of the most important relationships we have is with the FACT teams with Community Bridges, whom we just heard from. In order to effective partnerships, one of the most important things that we need to do is information sharing. So the probation officers are required to share the risk assessments, and I'll explain a little bit more about those in just a moment. The plans that come as a result of the information from the risk assessments. We have to share the pre-sentence reports, the terms and conditions of probation, and any other information that might be important to share teams, so that we can have a comprehensive approach to their supervision and their care. In turn, will share with us the individualized service plans that they create, any communication list, or any kind of enrollment or other information they have with groups or programs that they agree to participate in. So when this is done effectively, we'll have current working on all applications and referrals that have been submitted along their status, so they have knowledge on what is going on with their case regarding their clinical supervision and their probation supervision. Referrals are going to come from law enforcement only in the FEMA. So what I'm going to look at, like I mentioned a minute ago, is the risk assessment. We have two risk assessments. One is the OST, the offender screening tool. One is the FROST, which is the field reassessment offender screening tool. The only difference between those is the OST is at the pre-sentence level, and the FROST is done annually from that point forward. Individuals must score a medium high or a high risk on either of those assessments, as Community Bridges explained just a minute ago. We'll review their amounts of law enforcement contact over about the last 6 to 12 months. And we want the severity of the contact. We want to look at the frequency. We want to, are these what are sometimes referred to as survival crimes? Are they nuisance crimes, like littering, criminal trespass, that type of thing? Social officers to discuss the file that they're going to submit with the current team, whether it's an active team or a supportive team, can obtain their buy-in, and there can be a approval if necessary for a higher level of care. That would not miss the available resources. One important pieces of this is that the individual, the probationer or the member, must be agreeable to the FACT team, and they have to sign the release of information in order to allow for the information sharing of their protected information. You'll see a template for a FACT referral. As you can see, we have all their basic information, ways to contact them, and who current clinic is. So that when this goes to the FACT teams, they know to reach out to get all the information necessary for transfer. Another piece of information we share is the score from the risk assessment. We want scoring the actual number, level that they score as. So if they're told the 20, that's going to make them a high risk. We want to make sure that that is in there so that they know the criminogenic needs that they're going to look for. As 4 is on those big 4, the the antisocial behavior, antisocial cognition, antisocial peers, antisocial attitude. Incorporate that into the FACT referral, whether it's a conversation after it's been submitted or if it's via email at the time of its submission. We have a paragraph at the end of these that would basically give a little summary as to why we were submitting the referral. But take that out so that we could avoid any unintentional sharing of protected information. So a key aspect to this partnership for effective FACT supervision is cross-training. We need to make all members of the team, whether on the clinical side or on the probation side, have a working knowledge of what each other's roles are. So FACT teams should be well informed of each other's positions, what the responsibilities of those positions are, and the roles in the recipient situation. The FACT teams full understanding of the expectations, the requirements, and the restrictions associated with probation, specialized mental health course. To help with that is conduct what we call the Justice Series training. That's training that my partner and I do where we pick certain topics and we present to the FACT and the ACT teams and we try to explore as much of the details of probation's role in individuals' lives so there's a better understanding of the legal piece to this. Then officers should also be well versed in the FACT procedures, the housing processes, treatment and counseling, as well as the medication. Departmental policy is that within the first year that a probation officer is assigned to an SMI caseload, they should participate in training that's going to cover this, as well as court-ordered treatment, handle crisis situations, how to get a better understanding of the crisis system, and stuff. Another important piece of this partnership is communication. There should be staffings often to address the successes and the hurdles for each individual member. If somebody reaches a milestone, somebody reaches a goal, we want to make sure that we acknowledge that and that we give them the praise that they need. The research shows that that is going to work. We make sure if they have a misstep that we address it and we let them know track But we also, on the probation side, need to let them know what the consequences could be should they continue down that path. We want contact information is readily available for all parties to include the leadership either at the clinical side or probation. In email correspondence, we need to make sure that all parties are tied to that particular case are included so that we have consistent and effective supervision and communication. One important piece to the communication is that everybody has an equal voice in the staffing, so whether those are at the clinic, in the probation office, over the phone, or in court. Make sure that no one person feels that they are not being heard or they have less of a input than another. Once that, then the partnership starts to fall apart and then the member starts. So we have to make sure that that is a focal point. And at the end, we need to have honest and mutual respect for each other and each other's roles so we can best assist these individuals. A variety of benefits for the forensic addition to this type of supervision. There's an understanding of the criminogenic factors that impact an individual's stability, whether that's their sobriety, resident stability, or mental health stability. There's a familiarization of the court system. There's bail processes, the community supervision guidelines, and other legal procedures. A utilization of the sequential intercept model. A local peer support agency in the Phoenix area created a Maricopa County version of the sequential intercept model that I'll show you in a moment. They're able to effective discharge planning for our probationers, and this helps to reduce incarceration days, helps restoration costs, which can also help to improve one's mental stability that can be associated with incarceration. It marries the harm reduction supervision and risk reduction supervision so that we can do everything we can to help these individuals implement behavior changes into their daily lives. This incorporation of court expectations and requirements into the clinical supervision allows the members to understand that the fact teams have knowledge of what probation is going to expect, and probation is going to have a working knowledge of what the clinical team needs from them. This here shows you a copy of the Maricopa County sequential intercept model. As you can see, different intercepts and have our specialized courts in there. And one important piece we have is something called the continuity of care calendar. That's most going to be between intercept 2 and 3. This calendar is a non-appearance calendar, and what it does, when somebody is arrested, their incident is run through a system, and we have no idea if they have any kind of mental health concerns, whether they are SMI, GMH, TBI, DDD, or else. It's going to alert defense counsel who is in custody with mental health concerns, and it'll assist them in trying to get them out of custody and into services faster. So you can see there's a pretty clear delineation of duties between the FACT teams and the probation officers. Some of the other partnership are going to overlap at some point. I see some of the similarities might be, the FACT team is going to submit the housing applications, but the officer has to approve the location. We want to make sure that they're not going to be living with or near a victim, or if they're a sex offender, that they're not going to be living across the street from a school or daycare. Teams are going to assist medication monitoring, submitting the treatment referrals, petition the DTS, DTO, PAD, or anything else, planning, transportation, handling situations, as well as implement reduction approach. And the probation officers, again, with the housing approval, sometimes in the court as to drug testing, that they are enrolled, participating appropriately in their treatment groups. We also assist with the discharge planning. We notify the court of any kind of successes or any kind of missteps. We're also on the community safety and the victim safety in order to implement the risk reduction approach to this supervision. Thank you.
Our presenters, this is so rich and full of information. We are going to take a few minutes to answer questions prior to the conclusion of our webinar in a few minutes. And just briefly, before we take up questions, I want to notify you that SAMHSA and the GAIN Center are working on an action brief around FACT. So that will be something that we'll be looking to release in the near future. So just a heads up to watch out for that. So tomorrow we'll be holding office hours. So if you don't get your questions answered here and now, we'll have an hour set aside tomorrow with the panelists where you can call in and have a one-on-one discussion with them. It will be an open format discussion, so everyone on the call will be able to hear the information shared and the questions that are asked. Please email Erica Ihara to RSVP. And her email address is there on the screen, but it's also eihara@ic.com. Those office hours are tomorrow from 3 to 4 p.m. Eastern Time. I encourage you to take advantage of the opportunity to speak with these panelists to have your questions answered. So in the last few minutes that we have available, I do want to get started on some of the questions that have been asked here. And the first one is around Medicaid. So this is for all of the panelists. If you would just chime in with your perspective. This person asked, what have been the challenges to getting Medicaid funding for services provided by the FACT team? What types of services were able to get approved for Medicaid funding?
This is Dawn Whittington in the Maricopa County region of Arizona. We've been very fortunate. We have a regional behavioral health system that provides us the funding from our state Medicaid system, and they're very much a part of our partnership. I would say the more of the difficulties for us have come on when somebody falls off of that insurance. If they don't get it renewed in time, or they're in and out of something like that, often that presents a challenge. In terms of services, we have an integrated care license here in Arizona, so we're able to provide behavioral health services, individual group counseling, peer support services, independent life skills, as well as then medical services. So our visits to the PCP, the full range of medical care.
Does anyone have anything to contribute around Medicaid funding?
Hi, Betsy Claver. Just speaking for New York State, I mentioned the Medicaid funding for us is heavily based on face-to-face contacts with the client. So some of the challenges, especially around the forensic work, is when we are putting a lot of effort and resources into things like outreach or coordinating with criminal justice providers, or doing visits in correctional settings where Medicaid will not pay for those visits. And so sort of sustaining ourselves and provide those things that we think are essential to Forensic Act, but are not always directly reimbursed by Medicaid.
Okay. Another question is also around funding. How and agency vehicles and technology that the FACT utilizes. Is this funded through the state?
Dawn Whittington, it's directly a part of our contract with the state to include those things. So we then build that into our budgets at the agency level to be able to do that and to provide those resources to our staff. So really just then take what, the state is what we're getting through Medicaid, and then that into our agency level budgets. It kind of add to that, I think then the return comes in the engaged visits, the response time, which plays a part in reduced, hospitalizations, reduced incarcerations, things like that, which then impacts our outcomes and increases our incentive-based funding.
Anyone else want to answer that question? None. We have other questions, but we are now at the end of our webinar, so we will be sure to get responses to these questions from our panelists. Again, I encourage all of you to join us tomorrow from 3 to 4 p.m. Eastern for another opportunity to speak directly with the presenters today. Thank you so much for joining us today. We hope this has been helpful, and we look forward to having you join us at our future Gain Center webinar next month. Thanks so much. Bye-bye.